Good morning, everyone. I'm Alex Schaefer, one of the faculty of the Providence St. Vincent Internal Medicine Residency Program, and it's my pleasure today to welcome everyone to Medical Grand Rounds. We're broadcasting live today from Providence St. Vincent Medical Center on Teams Live. You can earn CME credit for watching either live or recording of this event, which is available via the same link as the invitation for the presentation today. A word about next week's Grand Rounds, which will be virtual only and which will be our last Grand Rounds of this season. The title is The Oregon Experience, Harnessing Innovation and Interconnectedness to Achieve Elimination of Hepatitis C by Dr. Andy Seaman. But today we have the 2024 Andy and Bev Hansel Endowed Chair in Applied Healthcare Ethics lecture hosted by the Providence Center for Healthcare Ethics. The chair was established in 1998 to ensure the presence of ethical expertise in patient care and medical education at Providence, and most recently was named for Andy and Bev Hansel in 2020. We'll be monitoring the question and answer throughout the session, so please do submit your questions and we'll hold them to the end as time permits. And now it's my pleasure to introduce our speakers today in reverse order of their presentations, Dr. Sarah Combs, Kayla Tabari-House, and Kevin Dirksen. Dr. Sarah Combs is a clinical ethicist and fellowship supervisor at the Providence Center for Healthcare Ethics. Her research focused on the clinical ethical obligation to take patient self-reports seriously and the implications of environmental and economic forces for clinical care. Dr. Combs earned her PhD from Georgetown University, is fellowship trained from Wellstar Health System in Georgia, and is certified in healthcare ethics consultation through the American Society of Bioethics and Humanities. Kayla Tabari-House is a clinical ethicist at the Providence Center for Healthcare Ethics. Her research interests are focused on life's most powerful transitions, particularly childbirth and hospice care. Kayla continues to publish in the bioethics space. Many of her writings focus on the intersection of maternal newborn health and racialized healthcare disparities. Kayla began her career as a labor and delivery nurse, where she specialized in therapeutic communication during stillbirth and pregnancy loss. She went on to study bioethics at Harvard Medical School Center for Bioethics, where she received a Master of Bioethics, and currently she is pursuing a PhD in healthcare ethics. Our first speaker is Kevin Dirksen, who serves as Senior Director at the Providence Center for Healthcare Ethics and the Andy and Bev Hansel Endowed Chair in Applied Healthcare Ethics. Under Kevin's leadership, the center has expanded its consultative and educational programs, as well as launching the Fellowship in Clinical Ethics and Health Justice next month. Kevin has published in national and international peer-reviewed publications, such as the American Journal of Bioethics, the Journal of General Internal Medicine, the Journal of Pain and Symptom Management, and Ethics Medicine and Public Health. Kevin lectures widely, representing the work of the center at local invited presentations, as well as regional, national, and international conference. Let's give a welcome to all three of our speakers. Kevin.
Well, thank you, Dr. Schaefer, for that lovely introduction. Sorry you had to introduce three ethicists instead of just one, but when I could think about what a fun way to end our year today, what about a magnifying impact from the other voices of the Ethics Center as well for the Hansel Endowed Chair lecture. So I want to start off with a thank you to our generous supporters of the Ethics Center, the team at the Providence St. Vincent Medical Center Foundation, as well as the Hansel family, after which this lectureship series and the Endowed Chair is named. And this year, I want to dedicate this lecture in particular to our center's longtime administrative assistant who died last month, Eileen Mooney, who was an indelible force on all that we did at the Ethics Center, and we remember her this morning. Here is our non-disclosure slide to make sure we're all good with all things CME. We have no conflicts of interest to disclose this morning. And I want to begin with something of a disclaimer about what you can expect here from this lecture series. As Dr. Schaefer mentioned, this is the penultimate lecture for the Medical Grand Round series. I know we're getting close to the finish line here, and every time we slot into this series, I kind of want to identify something that allows us to come up with something provocative, potentially make something that we can have some creative linkages, something that we think might spur some dialogue, and maybe even something fun. But the idea of fun for a bioethicist may be a little different than your idea of fun. So I want to disclose that right up front. You know, we talk about things like Oregon's Death with Dignity Act. We talk about things like futility in the ICU and cardiopulmonary resuscitation ethics, all these things. But I hope you think it's a little bit fun to at least talk about Oregon in bioethics today, right? We got this whole Oregon Trail thing that's pretty cool. My son in 4th grade did a whole unit on the Oregon Trail and got to go see a part of the Oregon Trail. That's all fun and good. But as we know, the Oregon Trail is also not all fun and games, maybe a lot of games, but you never want to see this pop up of meeting some untimely end in the famous, what is it, 80s, 90s Oregon Trail game, which I hear is being re-released. So for those of you who want to go back and nostalgically engage in that content, that's certainly available to you. So again, a little bit of a playful topic today. I'm hoping that this is something that we can forge some creative linkages and some dialogue. And the way that we're going to do that is try to set the stage a little bit about why we're framing up this lecture the way that we are, talk about a few aspects that Oregon is somewhat well known for in the bioethical space. Not to say that this is a comprehensive list. This could be much longer if we had an extra half hour, if we had, you know, into the afternoon even. But we wanted to identify some recent, some aspects that might be representative of how Oregon thinks in the bioethics space. And then we're hoping to leave some time for some Q&A. So be sure to be scribbling down some questions for us or some aspects of what you think this Bellwether Bioethics thing in Oregon is, how you appraise our tradition with how we're lifting it up this morning. So with that, let's talk about some background here. I'm going to set the stage and tell you a little bit about what is this bioethics thing. And why are we focusing on Oregon? So bioethics, if all the times in which as residents in the room have interacted with ethicists in the ICU on rounds or in a consult, or the other participants, the interdisciplinary participants of medical grand rounds, think about the work that we do, but kind of lack, what's that overall framing? Well, this is not a definition from the literature, but just something that sort of more broadly strikes me as what this field is. It's a multidisciplinary examination of ethical issues in both medicine, which we get, but also in biomedical research. So I was talking with Stephanie, our medical grand rounds coordinator, about her daughter graduating college just before and is working in the research space right now. There are bioethics of research as well. And indeed, when we look at the foundations, the source material for how we think about bioethics, it's both in the healthcare context as well as in the research space. But it's not a monolith. It's not sort of an ethics derived from one domain alone, but really draws from various historical, from scientific, from professional, from legal, accountable to the law, anthropological questions about who we are as humans and what things we ought to be pursuing, and more broadly social considerations that inform a broad contour of what we ought to be doing and maybe avoiding in the bioethics space. So it's important to know it really draws from a broad, wide-ranging source material. Ethicists today across the country are lawyers, are physicians, are nurses, are philosophers, are theologians, and that interdisciplinarity is sort of a hallmark of our field. And why is bioethics important? This image here, hearkening from a depiction of how Hippocrates could have been tempted by a king to come in and heal the army. is one where we see a version of this today, every day, around bargaining for more time, bargaining for more resources, for more treatments. It allows us to be able to have a way of thinking about both what we see in the healthcare and the research space in a way that tries to do some good work, right? It's not just merely to speculate for speculation's sense, or how many angels dance on the head of a pin, a kind of popular theological challenge to consider, but how do we reduce harm? How do we reduce deleterious impacts on patients or on human subjects in the research setting? How do we demonstrate good stewardship to be accountable for resource allocation questions? How do we steer this crazy behemoth of American healthcare toward justice, a topic that I tackled last year for this lecture series with our DEI colleague, Anthony Harrington? And how do we think about promoting human flourishing? At the end of the day, not medicine being an N of one, the given patient in front of us, but more broadly, how do we promote human flourishing? And bioethics really pops up in just a lot of different arenas. So for those of you who are involved either in residency or as faculty or in medical school or practicing on the front lines during the pandemic, bioethical questions were raised all the time around COVID-19 triage ethics. How would we allocate scarce personal protective equipment when our supply chains were low? How would we allocate scarce life-sustaining treatment or the resource of a hospital bed or critical care bed if more than one person qualified for that resource, but there was not enough to go around? In the research space, some of you may have read the book by Rebecca Skloot, The Immortal Life of Henrietta Lacks, or for those of you who like to click on a streaming app and watch the version where Oprah starred in the retelling of that book. But also, as I pointed out earlier, questions about resuscitation ethics. How are we providing care at the end of life in the ICU? How are we dealing with, in the top right corner, questions about wellness of the healthcare workforce and questions of moral distress, compassion and empathy fatigue. But also I mentioned historical. Bioethics is historical too. The picture in the middle is a depiction of a group of French scientists who studied, made important findings around vaccination and trying to get the local public health officer to believe them and actually implement vaccine science. Bioethics fits into every single one of these and more. And allows us to be able to have a vocabulary for engaging in discussions that are beyond just merely the exchange of opinions back and forth, or that keyboard warrior thing that we sometimes have happen. I'm an expert, here's my thought. But no, from the standpoint of the care that I provide in the healthcare context every day, caring for patients, here is what I'm concerned about regarding the latest reform in front of us. And so we would suggest, maybe we're a little bit biased at the Ethics Center, but that it ought to be a fundamental and practiced competency, not just for folks in the health policy arena, drafting laws and regulations and administrative rules, or for our partners in public health settings, municipal, county, state, and federal, but also for all of our healthcare workforce. And the conflict of interest is a little complicated because if we train you all up in this, you're not going to need us anyway, right? So maybe we're biased in that capacity, but also pretty committed to that as well. How do we think bioethically? Well, one way is to think through principles. The Providence ethical decision-making model that we kind of weave into our resident ethics elective rotations, our various ethics lunch and learns, our core program, how we do consults, is all about thinking through various principles and their application to a given clinical case. Probably the most seminal way of thinking bioethically in the field today derives from Beecham and Childress's mid-level principles or principlism approach of thinking through beneficence, non-maleficence, respect for persons and their autonomy, and justice. And again, that vocabulary allows us to be a little bit more compelling than to merely say what our opinion is, but to derive that from a focused set of reflections on core principles that others have access to and can debate with you. Well, I think justice calls us to this, or respect for autonomy calls us to that. And so I hope that that framing about how we think about bioethics will then allow us to think, well, what is this application to thinking about an Oregon bioethics? And is this really a bellwether bioethics here in Oregon? Why or why not? What I want to suggest with you, and I'm not the first one to offer this, is Oregon can be seen as something as a health policy test kitchen. Not just of late, with passing Measure 110 and then subsequent evolutions in that, most recently in the legislative session down at Salem, but in the 90s with the passage of the Oregon Health Plan and Oregon's Death with Dignity Act and a range of things in between. And so, you can have one of these and maybe be a little bit of note across the United States or internationally, but when you have so many developments that were really born out of this context, it makes you wonder what's unique about our context and how we think through various health policy dilemmas resulting in these novel reforms. And why Oregon? Well, because we all practice here, right? And this is where we can make an impact. And so, certainly I've been involved in various efforts down to testify for legislation. I know our faculty has, and as especially our residents develop their voice as both not only physicians, but on medical leaders in the communities where you'll practice, to be able to have a competency for the broader developments in the context in which you're practicing will hopefully allow us to have an impact. And I mean, it's probably easier for me to do Oregon bioethics than Delaware bioethics. I think we'd have less people in the room given our location out here. So a little bit of location. And when I think about Oregon more broadly, I was born here, grew up here, did leave for a while for education, fellowship training, things like that. I remember way back into discussions with family members about, wait, Oregon is not going to require wearing seatbelts like almost every other state in the nation was doing. Why is that? And how is that going to compromise our ability to derive federal funds for highway maintenance and things? Well, Oregon marches to the beat of its own drum. Some of us who have been here a long time have heard sort of that mantra. So we don't just see it with regard to healthcare or medical research alone, but broader questions too, where this ethos of the context in which we live informs how we vote and how we think about various things in Oregon. And so commentators have offered things like, well, the political and social culture of the state of Oregon fostered a unique environment. Oregon has a history of anti-authoritarian decision-making in the field of healthcare. For example, during the progressive era, citizens of Portland led a vociferous campaign against compulsory vaccination, and vaccination rates are interesting when you benchmark those to the United States still today. Or Oregon was a determinedly independent territory, fending off the national claims of Britain, Russia, and Spain before it ever became one of the American states. So this isn't just like recency bias talking about the last few years or last few decades. This sort of harkens to some of the origins of when Oregon became a state. Interestingly, also, more troublingly, Oregon also has a pretty pronounced history of racism. And I want to be sure for those of you who, unlike me, may not have grown up here and are aware of this history, to be aware of these forces that also push against how we have developed as a state and the various policies we develop. So state, local, and federal governments and their supporting institutions were knowing and willing co-conspirators in the proliferation of white supremacy in Oregon. Racist attitudes contributed to a posture of expectation and exclusion amongst the earliest settlers and their descendants. And various historians identify a continuum of violence in Oregon beginning in the Euro-American settlement to the contemporary day. So this is a part of also this history that informs how we think about questions like how do we care for patients at the end of life? How do we promote justice-oriented strategies to reduce health disparities across the state? This is fundamental to our sort of state DNA, this troubling history. And again, so this isn't just also right or about the time of statehood, but continues into this day. I put together this crude timeline just to show that this history of racism is not only something historical, but continues even into this day. So I don't want to make a causal claim and say this history of racism, this troubled history that I'm merely pointing to, not going into any depth or extended coverage at all, is necessarily wired to how we think about various developments that Sarah, Kayla, and I are going to talk about, but that this context is important to recognize. And sometimes things can be intertwined. Sometimes things can have intriguing connection points. And for those of you who think that's a little bit of a down note to talk about the racist history, I borrowed a slide from our session last year where Anthony Harrington and I pointed out that a piece that I think is really true is that an honest reflection of our history, including troubling chapters, is not anti-American or unpatriotic or unfaithful, but it allows us to be able to adequately appraise and understand what it means to be broadly considered part of the United States, or here specifically in the Oregon context. So let's do a quick deep dive before I hand off to Sarah and Kayla and talk a little bit about these three arenas: Oregon's Death with Dignity Act, Oregon Health Plan, and an example of home births and psilocybin. And all three of these arenas are things that have become noteworthy, not just in conversation after grand rounds over coffee, in the break room, or on the MAX train. Everybody's got their earbuds in anyway, right? But is one that has broached the national and international news and is debated elsewhere. So you have from NPR's coverage nationally conversations about in Oregon, psilocybin treatment is an experiment in real time from just a couple of months ago. Or just a couple of weeks ago, The Guardian, a UK paper publishing on how Oregon's right to die law has inspired other US states and countries. And way back when the Oregon Health Plan was first passed, this made national news as well. So these are all things that are sort of famous outside of our context as well. And if you pop into post-residency, go practice somewhere else, they might have an association with Oregon and say what we're doing with psilocybin, or decriminalizing drug policy with Measure 110, or Oregon's Death with Dignity Act. So when Oregon's Death with Dignity Act, just to spend a couple of minutes here, was passed, there was an interesting sort of, how did this ever occur? Oregon being the first state to legalize a pathway for assisted suicide in the United States. Where did this come from? What motivated Oregon voters? And one of the takeaways from a local political science professor at the time was that Oregon voters felt that this was less of a moral issue in their mind, that their religion, their way in which they were raised or taught, told them this was right or wrong, but more of a question of independent choice and end-of-life autonomy. And so we'll see some of these themes pop up again and again around autonomy, around choice, in a Bellwether Bioethics of how we do things here in Oregon. And it yokes to some of those early historical reflections on even how Oregon came to be. So what are some things that you should know about Oregon's Death with Dignity Act today, or specifically here in 2024? Straight from the Oregon Health Authority's website, what is it? It allows terminally ill patients who meet specific qualifications to end their lives through voluntary and self-administration of a lethal dose of medications that's prescribed by a physician for that purpose. So it's important to know that when this was passed, this was not passed in a way to articulate a right to physician-assisted suicide, Oregon's Death with Dignity Act, medical aid in dying, provider hastened death. You'll see there are a lot of terms for this, and the terminology we use often underscores deep meaning. But it was crafted in such a way that individuals and health systems could indicate an objection to participating in that process. And Providence, being a Catholic healthcare institution, has a long-standing, since really day one, of a non-participation policy in Oregon's Death with Dignity Act. That doesn't mean we're not asked questions about that or providing care for patients seeking that outside of Providence, but is distinct from the day-to-day practice here in Providence. And importantly, it's not a form of euthanasia. That distinction being the voluntary self-administration of medication versus the administration from another, which is the definition of euthanasia. While new processes continue to pop up all the time around medical aid in dying across the country, Oregon's was the first with measure, what was it, 16, passing in 1993, but only legalized in 97 after court challenges. And still this model remains a model for adoption elsewhere. There has always been and will continue to be a gap between the legal prescriptions written and the deaths that are tracked through the Oregon Health Authority website, which is thought to be very good data. And even its critics are very pleased with how this has been a data-driven approach in Oregon. But there's a gap, and a lot of commentators were initially surprised by that. What's that all about? They're also more in terms of what's new today, as opposed to maybe when you started residency or our faculty last got an ethics lecture on this, is that the long-standing waiting period between requests as well as the residency requirement that you have to be a resident of the state of Oregon have been eliminated in recent years. So those are developments that have expanded access to Oregon's Death with Dignity Act to non-Oregon citizens, as well as to those patients who fall into that too sick to be able to issue two requests demarcated by time. And finally, I think it's important to reflect that the vast majority of participants still report, and this has been a long-standing data-driven element from the start, that the loss of autonomy rating at 92% of participants is the highest reason of why patients engage. So to close, in some respects, aspects of Oregon's Death with Dignity Act have been very steady. With demographic pieces. And again, all of this information is on Oregon Health Authority's website, publicly accessible. Demographics have remained relatively stable. The reasons cited for participation have been relatively stable. That existing gap between prescriptions written and actual deaths from Oregon's Death with Dignity Act have remained. But there have been some expansions, and that's important to note, especially when its opponents claim that this is really a slippery slope to a sort of Low Countries, Belgium, Netherlands euthanasia paradigm. So there has been expansion in recent years, and it'll be interesting to see if that flatlines or if that continues to expand in the future. And obviously, perennial debates continue. Should doctors, should healthcare professionals be involved in these processes? Is it morally justified for one to request and to receive a prescription and take a medication to end one's life? Are symptoms ever not able to be addressed by modern palliative care? Even strategies like palliative sedation at the end of life. Is this something that is justified from the argument to relieve terminal symptoms at the end of life? So those debates have not been solved. They will continue to occur, but that's what makes bioethics interesting and allows me to then hand off to Kayla, who's going to flag another bioethical development in Oregon relating to the Oregon Health Plan.
Thank you, Kevin. I spot some fellow 90s babies in this room. Is that fair to say? Yeah, I'm getting some head nods. So I think it's important for all of us, but especially those of us who maybe were not old enough to remember when all of this unfolded, that the Oregon Health Plan is really something of a novel concept. And it was largely created and then implemented by someone who was an emergency room physician who later became the governor of Oregon. That's Dr. John Kitzhaber, and that was in the early 1990s. And so that really made Oregon, a national leader in healthcare reform, which is a pretty big deal. So the Oregon Health Plan at the time that it was first pushed through was not compatible with federal law at the time. Got so much attention that President Bill Clinton had to actually sign a waiver for Oregon in particular to allow the Oregon Health Plan in that version of it. This is in 1994, I believe, to take place. And within the plan's first year, nearly 120,000 new members enrolled, which tells you probably that there was a need, right? So today, over 500,000 people in Oregon are enrolled in Oregon Health Plan, and just on average, 1 of every 3 Oregonians is enrolled in OHP. Pretty staggering numbers. So Bill Clinton got some press for this. We see him rocking a slogan, healthcare, that's always there. And again, the Oregon Health Plan is Oregon's state Medicaid program. So we're not the only state, of course, to have a Medicaid program, but not every state does. And I think I could spend a full hour talking about the history of Oregon Health Plan and why it's so interesting, but I will just sort of hint at some interesting pieces about it. So one is that before 1994, there were really 2 groups that had access to this sort of new concept of the Oregon Health Plan. One of those groups were people who had pre-existing conditions that private insurance companies were not willing to cover because they were likely so expensive. And another group of people that were able to access before 1994 were folks who lived at a certain percentage below the federal poverty line. So this is not offered before 94 to everyone below the federal poverty line, but just people who were so far below it that they could qualify. And that option left tens of thousands, I could probably argue over 100,000 of Oregonians uninsured. And so after 1994, with this new version of the Oregon Health Plan, the state began to prioritize healthcare treatments. There's a lot to unpack there, right? Because that's starting to sound like rationing the more you get into it. So Kitzhaber created a commission that developed a list, if you will, that gave higher priority to the most effective treatments. How do you define effective treatments, right? That's a slippery slope in and of itself right there. And so every 2 years, the legislature would draw a line, quite literally, saying we can cover treatment option 0 to 502. Anything after that, you're on your own. And so people looked at this and said, wow, that feels like a very severe form of rationing that can negatively impact all sorts of communities. And I don't disagree with that, but I will say that experts have said you're really rationing here either way, right? So before 1994, while people who had access to this Oregon Health Plan or this version of Medicaid essentially had what was close to unlimited coverage for whatever they needed, you also had tens of thousands of people with no coverage at all. And then post 1994, you see that many more people have coverage, but it's not as comprehensive of coverage. So it's a bit of a pick your poison, if you will. And so suddenly we have this program that is covering a lot more people. And of course, that's going to draw news attention. This is a New York Times article from 1993. US backs Oregon's health plan for covering all poor people. I thought that was kind of an interesting way of phrasing it. I'll let you interpret that. And so what this left me wondering was, what about children? Where do minors come into this? Have we always covered minors? Is this a newer thing? Not until 2009, really, that new legislation passed that allowed the Oregon Health Plan to expand to really fully cover, this is Healthy Kids for a Healthy Oregon. And that covers about 80,000 uninsured children at the time that it launched. Now there are nearly 150,000 children covered by the Oregon Health Plan. So what's really cool about this is you can, pretty much directly compare Oregon to other states. Oregon, for example, has 94% of people who live here are covered by health insurance of some kind. I'm not going to say that that's perfect. I'm not going to say we don't still struggle with medical debt and all kinds of other complex aspects of our national healthcare system. or lack thereof, but we can compare this 94% to about 64% of people in Alabama, for example, have health insurance of some kind. So 1 in 3 people in Alabama don't really have access to health insurance at all. It's wonderful that only 6% of Oregonians don't have access to health insurance at all, although of course that could still be improved. So I can make a strong ethical justification for why increasing access to health insurance is incredibly important. But history tells me that folks are often more interested in a financial argument than an ethical one. I see some head nods. Yeah, it's probably not that surprising. So there's a question about improving outcomes and then improving costs, right? And the idea is that if we have more access to preventative care, we will improve outcomes and folks will be less likely to need that long stay on a med-surg floor in the ICU, and that will then improve cost. And so what I think is so exciting about Oregon, and I'll share in both of my examples here, we're allowing the United States access to our data. We're allowing researchers to our data that's really quite novel. And so this gets us to the Oregon experiment, effects of Medicaid on clinical outcomes. I'm sure some of my internal medicine folks have read this paper before, but we had this wonderful chance for a randomized control trial in 2008. And that's because there was a lottery system briefly of who got the Oregon health plan. So you can imagine you're an IRB, you're probably not going to want to approve a study that says this chunk of people gets health insurance and this chunk of people doesn't, right? That doesn't feel great. There's some ethical complications there, certainly. But because there was a lottery system, researchers realized this was a rare chance to look at a randomized control trial that shows Medicaid coverage. And what did they learn? Medicaid coverage and the Oregon health plan in particular increased the use of healthcare services. It raised rates of diabetes detection and management, lowered rates of depression, and importantly, reduced financial strain for patients. Now, is this a slam dunk, right? Everyone who gets, Oregon health plan, like, did we cure diabetes? We didn't, right? But we like to think that it makes an improvement. So when you think about, Medicaid, Oregon health plan, and improvements that can be made, we often think of that sort of like diabetes, hypertension, sort of classic things we're working on. I want to give you kind of an interesting example, though. The former labor and delivery nurse in me requires it. I'll define some of these terms, so don't worry if none of this makes sense, but I'm going to dip your toes into a case study. Imagine you're an obstetrician, and Jenny is a 28-year-old who was pregnant with her second child. At her initial visit, she tells you, you're her obstetrician, she wants to deliver at home. If it's too expensive to have a midwife at home, she says, no worries, I'll just use the instructions I read on a free birth blog that I read. This is actually not that surprising to you as an obstetrician, or if you're someone who follows out of hospital births in the nation, as the rate of home birth deliveries has been steadily increasing in Oregon over the past 20 years. So when we think of a hospital birth, right, that's when a pregnant person gives birth in a hospital. We might push ourselves a little bit to think about an out of hospital birth, right, or a planned community birth. And that's when a pregnant person gives birth either in a birth center or at home, and they're supported by a licensed professional. That can look like a few different things. I'll spare you, I won't get into it. This is a licensed person who's trained in delivering children, babies, who's going to attend that birth. And then we have this third category that's been rising in popularity, especially during and after the pandemic, and that's people who free birth, meaning the pregnant person delivers the child either completely by themselves or with the help of a loved one who has no training in delivering children. And so the wonderful thing about birth centers or home births, right, as you can imagine, is it's kind of this meet in the middle. Maybe it's not like the full hospital birth that you see in this slide here type of picture. Maybe you have a bathtub and a rocking chair and some wonderful things that make you feel more at home, but you also have access to some amount of life-saving equipment for either the child or the pregnant person or the delivering person, or you may be able to be really close to a hospital and facilitate transfer if need be. So I'll take you back to that case study. Jenny says, because now you know about free birth, right? You learned a lot today, Grand Rounds. Jenny says she wants to deliver at home, but if it's too expensive, because we know historically only folks who are able to spend $20,000 to $30,000 on hiring a midwife have been the people who get to deliver their child at home with a licensed professional. So Jenny's heard it's expensive and she's not wrong. So she says, if I can't afford it, I'll just read the instructions from a free birth blog. So you're her obstetrician and you're wondering about cost, right? You're thinking, what do I tell her? Does the Oregon Health Plan cover the cost of planned community births for some of its patients? Do y'all know the answer to that? It sure does. Yeah, if you are having a low risk pregnancy, the Oregon Health Plan, and again, there's certain criteria to meet there. It's not just for anyone across the board, but does cover birth at home or in birth centers that's supported by a licensed professional. And so as an obstetrician, you can sort of rest assured that Jenny's going to be delivering with someone who knows how to care for her. So what's important about that, again, I'm almost done here, I promise, but just that coverage and the pioneering spirit of Oregon allows us to gather data, which then allows people to research that data, and we publish that data, and that's really quite novel. So in 2012, Oregon realized, well, we're covering certain home births and birth center births. In our birth certificate data, how do we capture that? So it used to be either you delivered in a hospital or not. But we have to remember that some people deliver on the side of the road, not because they want to, but because they're driving to the hospital and they didn't get there in time. And those birth outcomes, we can imagine, are different from the birth outcomes of people who choose to free birth, are different from the birth outcomes of people who have a licensed midwife there when they deliver. And so this birth certificate change allowed us to understand those differences. And Drs. Snowden and Tilden at OHSU, another great New England Journal of Medicine piece, were able to examine in great detail, because of those birth certificate changes, planned out of hospital birth and birth outcomes. And I'll give you a high level of what they found. Turns out free birthing is really quite dangerous subjectively, but that if you delivered a birth center or at home with a trained professional or in a hospital with an obstetrician, the risk is really quite similar. And so that really changed the way that states across the country think about risk when we think of out of hospital birth. Sarah, will you take us to the next chunk? Thank you.
So Oregon as a pioneer in an awful lot of things, but Oregon has also started to do some pretty, is this a little bit better? This sounds better to me. Oregon has also started to do some pretty exciting stuff that has just started, which is going to guide in the future how people think about other kinds of medicine. So Oregon has, in the last 4 or 5 years, done an awful lot of some back and forth on drug decriminalization and drug law. I'm not going to get into all of that. I'm just going to start talking about psilocybin-assisted therapy, which is something that's very recently legal in Oregon. And here's why. Because what happened was not that psilocybin was decriminalized, but that psilocybin-assisted therapy was made illegal in Oregon. So what does that mean? Psilocybin-assisted therapy is when participants ingest monitored amounts of psilocybin, which is the psychoactive substance in what people colloquially call magic mushrooms, in a controlled environment guided by a therapist. It was designated as a breakthrough therapy by the FDA in 2018 for a heck of a lot of stuff. Promising studies have identified possible uses in treating substance use disorders, depression, suicidality, an awful lot of other things. Theories on the mechanism of action for exactly why this is effective and when it would be effective and in what doses this would be effective vary. And I'll talk a little bit why that is, but in part it's because there hasn't been an awful lot of research. Some credentialing organizations for somebody who would guide you through this require therapists to carry other clinical backgrounds for training, and some do not. Some require therapists to have had their own experience with psilocybin-assisted therapy, and some do not. So there's kind of a wide variety of stuff that this looks like, but this is generally what I'm talking about when I'm talking about this. So Measure 109, which became ORS 475A, made that process specifically legal and regulated in Oregon very recently. People who are seeking this have to be over 21. They have to be monitored by a state-certified facilitator at a licensed center using psilocybin cultivated by a licensed manufacturer and tested by a licensed lab. So Oregon created these categories of what's a state-certified facilitator, what's a licensed center, what kind of cultivation is okay, and what kind of testing do we want to do. These people do not have to be Oregon residents, but all of the rest of these things are regulated by Oregon. It can be consumed in an awful lot of ways, and basically eligibility to receive this kind of treatment is determined by the facilitators based on some like vague guidelines, which they're researching a little bit more. There are 25 separate facilitator training programs, which have produced 325 facilitators in the state of Oregon as of May of this year. So it's a thing that's happening in Oregon. It's a thing that's happening not insignificantly in Oregon. And it's a thing that's happening in an interesting twist here. It's incompatible with most other forms of clinician licensing. So as I said, theories on the mechanism of action kind of vary, and there are really deep debates about whether this is effective and in what ways it might be safe. And so for those reasons and for a number of others, an awful lot of credentialing organizations say you can't do both, or you can't do this under your license. And so this is kind of a completely separate set of people from what's known as allopathic medicine, from the folks that work in hospitals. This is not something that happens there. It is, however, monitored by the state of Oregon. And like with the other things we've talked about, it is something that the state of Oregon is gathering an awful lot of data on. There is not a lot of robust data on what psilocybin therapy looks like, on what is effective and ineffective in sort of context of psilocybin therapy. And Oregon has passed this year what's called Senate Bill 303, requiring that the folks who are facilitators of psilocybin-assisted therapy start to gather some data. So what kind of data does that look like? It's going to be available in 2025. I don't have a slide for you on anything interesting there. Come back next year, maybe. But here's the kind of stuff that they are starting to gather. So they're gathering stuff on demographics, they're gathering stuff on why people are seeking psilocybin-assisted therapy, they're gathering stuff on doses, they're gathering things on group or singular. It's not exactly a randomized controlled trial, but it is the start of what is going to be the biggest form of data on this practice. Which means that Oregon is going to, in the next sort of post-2025, serve as an example for an awful lot of states, and the data that's going to come out of Oregon is going to guide an immense amount of practice in other places. Psilocybin is decriminalized in some cities. It is regulated and decriminalized in one other state. Nowhere else is doing it medically in the way that Oregon is, but there are campaigns to do that in a number of other states. So in California, psilocybin decriminalization passed, but was vetoed by the governor because he wanted therapeutic guidelines. So the understanding is that once the Oregon data comes out, if it looks good, that's going to guide what California's law looks like. And if it looks like, oh, this is dangerous and bad, that is going to mean that that's not going to happen in California. There's a number of other states and a heck of a lot of cities that are looking at decriminalizing psilocybin, and in particular are looking at making psilocybin legal for medical reasons. And so this Oregon data is going to be genuinely what drives this for the rest of the country. What does that mean? That means that Oregon clinicians are some of the first people, all of you in this room and those of us watching, are the first to have patients who are seeking psilocybin therapy either concurrently to treatment from you or for the same stuff you're treating them for. Because there are no guidelines specifically limiting what you can seek psilocybin therapy for, so there's a large group of patients seeking it for all sorts of different kinds of things, which means you are the first group of people who are going to have a patient look at you and say, yeah, I'm also seeking psilocybin therapy for this, and who are going to have to decide how to respond. This means that you are also going to be guiding all of the people from all of these other states and having experiences that are going to guide them, because people are looking to Oregon for a heck of a lot of stuff. For experience, just for reports about what this is going to look like. They're looking to Oregon for guidelines. So when eventually guidelines on sort of how to respond to patients who are also seeking psilocybin therapy get written, they're going to be written based on the experiences starting with Oregon clinicians. They're looking for guidelines on risk mitigation, strategies for how to respond or how to reduce harm, and for inspiration. So with only a little bit of time left, I am going to say that I think that there are some ethical considerations that our experiences with psilocybin therapy already have guided, sort of how to say, how to respond to a patient who's seeking this. And I think that this also can help guide us in other ways. Some ethical considerations for a patient who is also seeking psilocybin therapy are the kind of ethical considerations that I think also apply to patients seeking complementary and alternative medicine, which is a huge population of folks in Oregon. So this is a very Oregon thing to have started to think about. What does that look like? That looks like thinking about relationship maintenance here, thinking about a response that is polite, thinking about a response that sort of takes seriously that this is something that's really going to help a patient in their mind, sort of thinking about why they're seeking this. Noticing that autonomy is a huge value for folks seeking psilocybin-assisted therapy. Studies show that that's one of the main reasons people want to, because it's kind of independent and self-guided. A little bit of humility, maybe not immediately starting with, well, there's no good data for that. There's not, but it's coming. And a really good way to approach patients is by asking more questions. Having basic knowledge of the ways that it interacts with other things. Thinking about ways to prevent harm when we see harm to patients, so identifying what that harm might be in specific contexts, and thinking about what your professional boundaries are. And that's going to look like stuff like having thought kind of carefully about in what ways am I comfortable prescribing things that might interact here? What kind of advice am I comfortable giving? Am I saying, I don't really know anything about this and I can't give you any kind of advice? These are the kind of things that Oregon clinicians are going to have to start to think about and have to start to titrate to folks seeking other kinds of therapy. Which is great because Oregon is one of the states in which people use the most complementary and alternative medicine. And so we have been thinking about this before. We are all very qualified. What does that look like? Complementary and alternative medicine are alternative whole medical systems, mind-body interventions, manipulative methods, energy therapies, and biologically based therapies, which are non-allopathic. So we're starting out something really exciting. We're starting out something that might look a little bit scary. But as folks working in Oregon, we're extremely qualified for it, and we are going to be the ones that are driving what these things look like in the future. So I'm going to go ahead and hand off to the summary.
All right, so we're right about at Q&A time, but a couple of things in summary across these three presentations. We think that Oregon has and continues to lead the way when it comes to various complex bioethical issues of the day, whether you were born in the 80s, 90s, or later, as this recording maybe gets watched someday. Oregonians aren't afraid of stepping into the unknown and trying to learn as much as we can and iterate. That data element, as I mentioned during the session on Oregon's Death with Dignity Act, has been huge, celebrated really on both sides, so that we have adequate data to inform the ongoing debates. And I think, as Sarah pointed to, a little bit more uncertain about what that data element is going to develop in the psilocybin experiment. There have been expansions associated with some of our explorations in these arenas. And it sort of also shows us that with some pivots, measure 110, the backpedal we saw in Salem this last spring, sort of means that health policy is never quite fixed. It's always iterating that way. And I think that at least maybe offer you this image of maybe not taking sides, as Oregon's bioethics, whether we call it a bellwether or not for the rest of the country internationally, is positive, negative, or somewhere in between. Let's just be descriptive about it. It clearly is a thing. And let's try to track that so that we can be involved in the debates about what we're seeing and what we're developing, maybe who we're becoming in healthcare in Oregon. And not have our heads in the sand as we avoid being a part of the discussion. And back to that troubled history that I pointed to, perhaps with more knowledge, with more engagement, we can steer more toward our better selves and not our more troubled origins in this arena. So with that, we'll pause and take some questions here in the room and see if we've got any comments online. Thank you. All right, so I've got one question here. It says, I've heard people say things like home birth is illegal. Do you think there's an argument to be made that hospital staff ought to have a better understanding of statewide policies and legal aspects of healthcare like you've presented here? I'm sure that's a Sarah.
That's a great question. I do actually think it ties into what Sarah presented in terms of it is important for us to, in the context you presented, maybe understand complementary and alternative medicine, even if we're not the ones prescribing it or interacting with it directly, in the same way that I think it is important to understand, at least to some extent, how policy and state laws and even health insurance coverage affect the patient population that you serve. And I hesitate to say that because I know we're all so busy just trying to get through 12-hour night shifts. So maybe that's a tall ask, but I do think in a dream world, every person working in their own sort of particular field would have an idea maybe of what is or isn't legal or those sorts of things outside of the hospital setting, not just to interact with patients, but also to remind us that there is a whole world of care that patients access outside of the hospital setting. And I think it's important to broaden our scope there as much as we can to understanding.
Yeah, certainly not an expert here, but would also say from an ethical perspective, you can argue that if we're being asked about these things and it's coming up in the therapeutic encounter, if we know that this is a common refrain, to know a little bit of the data and for our duty under informed consent to start to supply some of that information to make that a more informed decision about what care is accessed, I think is important. Yeah. What else? Got another question in the chat. Anything I can coax out of the room here? All right, I've got one here that says, Kevin, you mentioned in a slide that Providence has a non-participation policy in regards to Oregon's Death with Dignity Act. What does that mean? So in Oregon, if you're an ethicist, you need to be able to speak to some of these developments, and we've got slide decks on a great many things, ranging from psilocybin to health policy reforms, including Oregon's Death with Dignity Act. I would say that that's a competency for ethicists, whether you practice in Catholic healthcare or not. But specifically, we do get these questions because of established church teaching and Providence's long-standing policy since the 90s on non-participation. What that means is Providence employees and institutions do not participate in a patient who is attempting to access Oregon's Death with Dignity Act in terms of providing information, the formal competency piece, to be involved in a formal referral for that process, or of course to engage in the writing of a prescription of a lethal dose for patients. But what that non-participation policy doesn't mean is that there's any kind of gag order about talking to our patients about what their needs are, what is motivating a request, what they may have access to in Oregon or not, and communicating that information neutrally. Across an integrated healthcare delivery system like Providence, we see patients in the hospital, in our clinics, in specialty care, in home and community care, home hospice, some of which are accessing care like availing themselves to new resources and seeking access to psilocybin, or maybe discussing with another provider about access to Oregon's Death with Dignity Act. And in that setting, we don't fire patients who are engaged because of Providence's longstanding non-participation policy. We continue to provide that same level of care that we would offer to anyone else. The failure to do that would, from an ethics perspective, be patient abandonment, and that would violate other core ethical principles and our Catholic identity as well. So it's important to know what not only we can't do and to be clear about that line associated with our employment, but also be very clear about what the resources we can offer. So the question was specific to Providence's non-participation policy, but there is also conscience opt-outs for providers and other clinicians as well who feel like that's not what I should be doing as a human person based upon my religious teachings, what have you, or even as a medical professional, that I do not believe that a physician should be involved in that or a nurse should be involved in that. And so again, as I said, there is no right to Oregon's Death with Dignity process, but it is a process that allows for terminally ill patients to be able to seek out that resource from a willing provider at a participating institution. Dr. Schaefer?
I wonder along those lines, given that Providence's policies regarding abortion and death with dignity are likely well known, I wonder how many patients may be engaging in self-censorship around these issues when they see providers at Providence, and whether because of that self-censorship we have some sort of obligation to be proactive in bringing up these issues and options.
Yeah, that's a great question. I think what's most has occurred in conversations brought to us or concerns brought to us is, am I not allowed to talk about this if it's brought up? But you're taking the argument a step further and saying, well, if there is that knowledge out in the community, ought we be engaging with our patients, maybe proactively at the point of accessing coverage in care, or maybe particularly when clinically indicated based upon, say, in this case, that we have a patient who has a terminal illness and is maybe struggling with their symptoms. I think that you could argue that a proactive conversation, as long as it is neutral, it's not recommending for that process and running into Providence's non-participation policy, is not only ethically appropriate, but maybe ethically obligatory in this context, so that there's an awareness of what is available that way. But at the end of the day, I would just point to that principle of patient abandonment, and we would never want to, because of our non-participation policy, abandon patients to feeling like I can't ask of that, and being proactive, I think, is a good strategy. So with that, we are past time, and thank you for participating in the penultimate Grand Round session, and look forward to the last one next week, which will be virtual. So don't come expecting coffee here in the room, but join on your screen with your mug full at home or up in your office. Thank you.